everyone? Better in OpenSim than yesterday? All the projects completed? Yes? No? Yes, sir. Ah, sir. Thank you. So today, what we are going to do is we are going to brief over what is human walking, what is human gait, what is a healthy human gait, and what is unhealthy human gait. And if we want to do research in human gait, what precautions are necessary, what tools are available, and what research fundamentals we need to use or we need to care for when we do human walking research. Is that a good information for you all? Okay. Everybody is interested in human gait? Then similar fundamentals could be applied to the upper limb also. But because time is short and the lectures are huge and you also want to work on your projects, I will only cover the gait, the lower limb analysis. Okay? There's nobody here. So question is, do we walk a fine line? We start with a definition of biomedical engineering. What is a biomedical engineering? It is the combined application of engineering principles and design concepts to medicine and biology to advance healthcare treatment, including diagnosis, monitoring, and therapy. This is biomedical engineering. Then we see what biomedical engineering means in terms of analysis, in terms of walking. Walking is a very, very, very complex phenomenon. You think that you walk, but you don't think how many complex processes they go behind this walking phenomena. Gait analysis, which is a study of walking, is a systematic means for analyzing one's gait, including joint motions, joint movements, and muscle activation patterns. We all now know what do these mean, right? In absence of pathology, gait appears coordinated, efficient, and effortless. You never think of walking as something that bothers you, because you walk normally. You are all healthy individuals. You walk. You don't think that I am putting a lot of effort, stress, energy in doing this job. But ask somebody who's old, your grandpa, grandma, they have some problems in their knee pain, hip pain. Ask them, how is walking for you? They will say, hell, we cannot. Ask them, what do you prefer? They'll say, we'll prefer a wheelchair. We'll prefer a everything in our bed or at our place. We don't want to walk anymore. Why is that? Because efficiency, the coordination and effort are very low. So let's take a brief introduction about walking. When we study walking or when we study gait analysis, there are three basic approaches to look at gait. The first one is dividing the gait cycle according to the variations in the reciprocal floor. That's a stance phase and swing phase. Second is the time and distance quality of the gait cycle, stride and cadence. And third one is the functional significance of the events that happen during walking. Heel strike to toe off. A single cycle starts with a heel strike and ends with a toe off. No, I am not wrong. A single gait cycle starts with a heel strike and ends with another heel strike. But what we can study is we can study the events that happen between heel strike to toe off at a time. Or we can study the events that happen during the stride and cadence. Or we can study the events that happen between a stance phase and a swing phase. So everybody understands what is a stance phase and a swing phase? Can anybody tell me what is the stance phase? When your foot is planted on the floor, the moment from your heel strike to toe off is stance phase. And from toe off to next heel strike is a swing phase. And stance phase and swing phase together form a gait cycle. On one side, other side, right and left. Yes? Okay. In walking, we have two units. A passenger, which is upper body, which we call hat, hands, arms and trunk, and a locomotor, which is a lower body. So a locomotor unit carries a passenger unit. Locomotor unit has two lower limbs and pelvis. It has 11 principal articulations. What are articulations? What is articulation? So when I say 11 articulations, what does that mean? Joints. 11 articulations means 11 principal joints working in the locomotor unit. Actuators, they are finely related activity of 57 muscles. Now imagine every single time you take one step, one gait cycle, you are activating, deactivating 57 muscles with their finely coordinated activity. If you can't, then you become pathological. Any single muscle that doesn't work makes you pathological, gives you pain, gives you abnormal gait, gives you lots of problems. Okay? And we have livers, which are bony segments. Yes? Now let's take an approach to divide the gait cycle into an understandable way. So we start with a stride, which is a gait cycle from heel strike to heel strike. We divide that into a stance and swing phase. Yes? Can we divide it further? Yes, we can. Stance phase is mainly divided into 5 phases and swing 3 phases. What are these 5? Initial contact, and they are intuitive to understand. Initial contact, loading response, mid stance, terminal stance, pre-swing phase, which is followed by initial swing, mid swing, terminal swing. It's easy to understand? Yes. Then we have some functional characteristics attached to each of these phases. The initial contact and loading response relates to the weight acceptance on your foot. Then your mid stance and terminal stance relates to a single limb support. Why? The mid and terminal stance, in that phase, you are only on one leg, other leg is in the swing motion. And then pre-swing and 3 swing phases, they are swing limb advancement. They help you swing the limb in advance yourself. The locomotor unit carries the passenger unit. Easy to understand so far? Yes. Now, how do we quantify this gait? What are the means to quantify these phases? Qualitatively you say, or you can say, that this person is limping, or this person is having pain, so he is having short strides. This person has a slow cadence. Qualitatively you can. How do you say that quantitatively? And when you say it quantitatively, in what terms you can say it? When I want to quantify gait, what do I use? Instruments and machines. After using some instruments and machine, what do I do? What are the quantifiable parameters of gait? In what terms you report this gait? How do you report? Joint angles. If I am reporting joint angles, it comes under what? It comes under what? Kinematics. Yes. Joint kinematics are the parameters that in which we can quantify gait cycle. Yes or no? So we use some instruments which are mostly motion analysis system, EMG and force plates to quantify gait. These are state of the art technology or technique to quantify gait. Everybody now understands what's motion analysis? Yes or no? What do we do in motion analysis? We put markers on the strategic points on the body. We get some infrared cameras. Then we record the motion of these markers or trajectory of these markers in space while the person is walking in a laboratory environment. At the same time, we have electromyographs, mostly surface electromyographs, and we have force plates in synchronization with walking and in synchronization with what we record on these markers. When we do that, we have complete information about the muscle activations, about the vertical ground reaction forces, and about the marker trajectories for a single gait cycle. Yes or no? Now, if you have the marker trajectories and if you have the vertical ground reaction forces, what do you use them for? What do you use them for? To calculate? To calculate joint kinematics first. Then you can calculate joint. What did you learn yesterday? Joint moments and joint forces. Then you can also calculate muscle forces. So all this is quantification of gait. Yes or no? So, the measurement system is this, and then you quantify that. Then there are other two ways to quantify gait. One is stride characteristics, which is determine overall walking capability. This is a simple way to measure or quantify gait. And the next one is energy cost measurements, which gives you walking efficiency. How do you quantify energy? Or let me ask you this, given a open sim model of your lower limb, can you quantify energy costs when that model is walking? How many say yes? 3. How many say no? How do you calculate energy? What is energy? Question is simple. Given an open sim model, can you quantify energy? Given all the measurements coming from there, and given an open sim model, can you quantify energy? What is energy? So, can you calculate that? So, if you have open sim model, can you do that? Yes? Okay. So, now answer is there, answer is? So, if you have open sim model, you do not only calculate joint kinematics and joint kinetics, joint kinematics and inverse dynamics. What you can also calculate is that comes under kinetics. Okay. How does it look like? Is this. I do not know if everybody have seen motion analysis system, but you have a lab space in which there are infrared cameras, which you can see that are put on the tripods. Here, these are the infrared cameras. In typical state of the art motion analysis system, there are 8 and more cameras that are surrounding. Here are instrumented treadmill, where if you want to do the running studies, this treadmill, the belt of the treadmill is embedded in it. So, when you walk, you would get all the forces of walking. When you run, you will get forces of running. There. These AM electrodes you put on the muscle belly. These are surface EMG electrodes. Then using the marker set, plate. Be so now imagine you have a motion analysis system, you put the markers. When you put your knee markers and hip markers and ankle markers, it is not necessary all the time to take that data into OpenSim. OpenSim didn't exist all the time, or let's say you don't have a capability to work on OpenSim. What people do is they have built programs which would take these marker sets, take the positions of these markers, for example, knee markers, medial and lateral markers. They draw a line in between, take this line as the center of the knee joint, define in your OpenSim. Ankle, same way for the hip. And then trajectories, we can quantify kinematics there. Yes or no? So what is the difference between the way they do it and the way OpenSim does it? Say it again. Yeah, but if I have a marker set and I have an inbuilt program in motion capture system which gives me the kinematics, and I have OpenSim which also gives me kinematics. So which one should I believe? Will there be a difference between these two kinematics? Will there be a difference? First, who says there will be a difference? 4. Who says there will be no difference? 1. Others don't know. So the answer is yes, there will be a difference. What happens when you have the marker set and an inbuilt program to get the kinematics as an outcome of this motion capture system? They have set of joint coordinate systems embedded using the markers. We don't. We use markers to move the segments. Can you get it? We are using the markers to move the segments, not to get the joint center of rotations. We already put in our joint center of rotation joint coordinate systems in x and y and z axis and how they are going to move relative to each other. We have already put that in our model. Now what is happening? It's a confusion. A inbuilt model give me some kinematics. Model will give me another kinematics. Which one to trust? What do you think? Which one to trust? Who will? Nobody. Who will trust the inbuilt analysis system? All of you. All of you. I will trust OpenSim more. And why I will tell you. That are defined based on the marks, they are arbitrary. They are not the real joint rotation centers. Okay. What marker based models will give you are marker dominated joint kinematics. Whereas your model is built on physics based joint system and your markers are there to move this joint system. So we do the scaling, we do the inverse kinematics to match or register your marker, the experimental marker set, to your model set, so that your model comes in the domain experiments and then you can move the model using a trial marker set. And because you identified what are the standard joint coordinate system for the knee joint that are applicable to your research, they are much more to be trusted than the one that is out of it. Yes? Convincing or no? Not yet convincing? So imagine somebody put the markers not exactly on the knee joint but little bit low. Then inbuilt program will say that that is my knee joint. Is that true? No. But it will still calculate everything based on that. Is that true? No. What you can do in your OpenSim, that you can place the markers on your model exactly the way they are placed here. So the markers only are there to move the model, not to give you an analysis of the joints. And that's the difference. You see, in an ideal world, if the markers are placed exactly at the joint level, all of them, as your OpenSim model, both results should match. But that's an ideal world. Never happens. So I would trust the model more than that is coming from the analysis system. Okay? So walking, healthy looks like that. And as the person walks on the force, we collect the data. A average normal hip flexion extension looks like this. A complete gait cycle from 0% to 100%. We do to this gait. All of them. We know approximately which phase lasts for how many %. Divide it. And then we can study individual of this hip flexion extension only. You can have hip rotation, then you can have ankle flexion extension, ankle valgus rotation, ankle internal external rotation. All these guys, everyone will have one curve. Divide that into phases, and you study each phase, whether that phase is performing normally or abnormally. Yes? Same thing. Pelvic, you have 3. For you have 3. For knee, you have 3. I'm not going to go over this. For ankle, you have 3. What you can also get from the force plate is vertical reaction. It right, you can identify in force. Everybody who walks should have a more or less amplitude of this curve. If somebody doesn't, then it is not healthy or normal, it is pathological. Could be a painful walk. Then we put all these guys with kinetics, joint movement, an average for healthy population for joint movements and joint power. Then we compare these with that and see that is there something wrong in somewhere that is not producing enough power or producing too much power. That means losing energy. Then we have EMGs. We take each EMG. EMG signal looks like that. That gives you activation whenever the action potential. Based on, you can identify whether the muscle is active, reactive, pattern, known for every single muscle that can be identified using surface EMG. So if there is something that is not making sense or that is not matching with the typical pattern, you focus on that. You see all the typical patterns for all the muscles, or most of those 57 muscles is known here. So there are some prerequisites of normal gait. What are these prerequisites? Sorry. Before I go forward, questions? If you don't ask, I don't understand. If you don't understand. Okay, so what are the prerequisites of a normal gait? You should have a stability in. Why? If you don't, you can fall, or you can have a pain, or you can have what? Doctor can answer. Yes. So you can have everything that can go wrong if you don't have a stability in stance phase. What is in swing phase? Toe clearance. Everybody with us? We should have a toe clearance in the swing phase. If not, we will trip and fall. You should have appropriate swing phase pre-positioning of the foot. What does that mean? Your foot should not be here when you are walking there. In certain cases, it may go like that. You should have adequate step length, not too small, not too big. Adequate. And you should have, on top of all, an energy conservation. If you don't, that means you are using too much energy to walk. Now, when I said the first day that you will learn how to walk better at the end of this course, this is what I meant. You will start judging your own walk after this, and you will see whether you are spending too much energy just by walking. Yes? Then what is a pathological mechanics, or what is a pathological condition in gait? We say that disease may differ in their primary pathology. The abnormalities they impose on the mechanics of, there are 5 different types of abnormalities. First one is due to deformity. Deformity of higher, louder. Deformity of bones, muscles. How you can have deformed ligament? Ruptured. Okay. Muscle weakness. Muscle weakness leads to what? Abnormal force production, inadequate force production, muscle fatigue, sensory loss, lacking neural command for execution of walk. Okay, that's a sensory loss. What else can be sensory loss? Maybe you should explain them the concept of proprioception, because they don't have it. So what he's saying, what he's saying is that you have a problem in your proprioception. Everybody knows the concept of proprioception. What is a proprioception? Is your ability to understand the position of your body and limb in space, in the environment. That is proprioception. If I am putting my hand here, I understand that my hand is here. If I am moving my hand like this, I understand I am moving a hand like this, and then there is an obstacle here, I should not hit it. This is called proprioception. If I don't have that, I hit it and I don't even know that I should control not to hit it. So that control, when it's lost, is proprioception. Is that more or less? So if you don't have a proprioception, that comes sensory loss. Okay. Pain. You can have pain without any reason. As I told you, patellofemoral pain most of the time comes without reason, at least no the reason yet. Or there could be any other pain due to diseases like arthritis. Yes? And then there is impaired motor control. What is motor? What is motor in the biomechanics terminology? Anyone else? Motor is muscle. Why it is called motor? So now you understood that it's called motor. Muscle contraction is called twitch. Muscle is called motor. A motor unit is what? Is a muscle. Entire muscle is a motor unit. Then we will see each of these pathologies with the examples. First one, deformity, where tissues do not allow mobility to attain normal postures. Contracture is most common cause. What are contractures? What are contractures? What is contraction? When muscle twitches, it's contraction. What are contractures? Are continuous contraction of a muscle, involuntary, is contracture. When you have a contracture, that means one of your muscles are always contracting, and when they are always contracting, my wrist muscles are always contracting. So I am always like this. I cannot make my wrist straight because it's always contracted. So now if it is always contracted, that means it is always applying force on the wrist joint in this direction. Yes or no? And then there is a law called Wolff's law. There is a famous researcher, Wolff, back in 17th century, who said that a form follows function. That means the form of your joints or bones will follow the function they are meant for. So if the function of this joint is always like that, it will start deforming slowly. That will lead to deformity. And that's what happened here. I don't know if you can see it clearly, but many different things. It a born deformity as well, as we can see. Like somebody can be born with shorter muscles. It could be, it mostly is due to neurological disorder. Yeah. Then there are other sources of deformity. These are joint contours, congenital disorders, as I was saying, and such as clubfoot. Then second one is muscle weakness. Now I don't know if you can see that, but there is a healthy muscle volume here, and there is a atrophied or less muscle volume here. Can you see that? It's insufficient muscle strength to meet the demands of walking. Disused muscle atrophy or an neurological impairment contributes to this limitation. What is disused muscle? The muscle that is not used goes dead. It says, I have no function here, I will rather die. Okay. In case of muscle neuron diseases, weakness is the only impairment. Polio, Guillain-Barré syndrome, muscular dystrophy, and primary muscular atrophy. These are the examples of motor neuron disease. There is a motor, there is a neuron attached to it. When it is diseased, this is what happens. In terms of sensory loss, we have an impaired proprioception. Now everybody knows proprioception. What is the impaired proprioception in walking? You walk with a lot of expenditure on energy by unnecessarily moving your legs farther or higher. That's an example. Walking is slow and cautious even with a moderate sensory impairment. You close your eyes and try to walk. You will either fall down or you will walk slowly. Yes or no? That's one of the sensory impairments or no? It is not visible, so often ignored most of the time. It's a very, how do you say, under focused domain in pathology, the sensory loss, because there are no standards to describe the sensory loss. Proprioception has 3 grades. It is absent, or it is normal, or it is impaired. Pain. It's an excessive tissue tension which is the primary cause of pain. Joint distension related to trauma or arthritis is a common situation. As you can see, there is a swelling on this leg which is caused by excessive tissue extension. Causes pain. Everybody has pain sometime in your life, yes? Then impaired motor control. A central neurological lesion, a damage to your neurological system, can lead to impaired motor control. What are the examples of diseases that comes under this category? Stroke, traumatic brain injury, multiple sclerosis, tetraplegia, paraplegia, cerebral palsy, dystonia, hydrocephalus, infections and tumors. Lots of under motor neuron, impaired motor control. One of them here is dystonia. OP. You can see the girl, her hands are not moving in a correct way. Her left hand is okay and her hand has a dystonia. Can you watch it again? See that? So that's an impaired motor control in her right hand. Now, there are gait abnormalities which are common and which are defined patterns in the clinical world. We have some common abnormalities which are reduced or increased cadence, equinus gait, stiff knee, hemiplegia, festination, forward trunk flexion, choreoform, circumduction. And then there are specific definitions of the gait abnormalities, which are under myopathic gait, choreoform gait, hemiplegic gait, diplegic gait, neuropathic gait, Parkinsonian gait, ataxic gait. Each of these gait pathologies or gait abnormal gait patterns has a specific symptom that a clinician can recognize and categorize as one of these gait abnormalities. Now imagine you have so many different gait abnormalities and pathologies, and each one of them you can model using OpenSim. Almost each one of them. There is plenty for everybody of you to take one and work on it. Because no matter whichever you take, I can guarantee you that you will have a place there to prove something, to find out something that nobody else found. I can guarantee you that. So I don't want to cover all these gait patterns, but if you want, so now when we have one of these pathologies and we want to quantify pathologies rather than quantify a normal human gait, that is called clinical gait analysis. Okay, and there are certain rules and regulations to follow when you are doing clinical gait analysis rather than doing a normal human gait analysis. Why? First, the reasons performing clinical gait analysis. Why it is needed to have clinical gait analysis? To see how much abnormal they are than normal. Quantify the abnormality. If we can quantify the abnormality, we can have good rehabilitation practices in place. In the follow-ups of this rehabilitation, we can see if the person is improving using these quantifications. Yes? Monitoring intervention, as I said, prediction of outcomes. Which management options are best and how patient? These type of questions we can answer using clinical gait analysis. In clinical gait analysis, we have gait deviations. There are kinematic gait deviations, and there are deviations. The kinematic gait deviations, they are controlled, measured in terms of index or gait index deviations into long, continuous, curtailed, delayed, 100% out of, and all these categories we can quantify using clinical gait analysis. How do you design a clinical gait analysis study? A clinical gait analysis study is mostly done in motion lab. So that means you should have first what? Lab setup. What lab setup will have? Treadmill, force plate, cameras, EMGs, markers to place on the body, and a strong computer to collect all the data. Yes? Okay. So we start observational gait analysis. This is what clinicians do, physiatrists' eyes. Questionnaire that they ask the patient and get assessment of any gross abnormalities in person's walking patterns, which is followed by a study design, like how many patients should be included in this study. What we are studying is whether how much pathological is your joint kinetics and kinematics parameters given a control and a abnormal group. So we should have a number of controls and patients. We narrow down the patient population by pathological index. If you see there is a GDI or there is another indexes, if this index has 5 level 1, 2, 3, 4, 5, you want to make study there are only level 1 patients involved, not all. If all are there, that will confuse your design, that will confuse the analysis of results. So what you should have is a narrowed down population within your controls and within your pathological cohort. Design data collection procedures, one session or multiple sessions, variables of interest and single or multiple observers. Then research protocol, an approval from the ethical committee. You cannot conduct such just because you want to and just because you have a lab. You still need to get an ethical approval to conduct research, and this has been agreed in all the countries by certain regulations, even in India. Okay. The third step is detection. You have capture G and your video data. The next step is data analysis. You quantify gait kinematics and kinetics, appropriate software. Now that software for you could be an appropriate, the one that is already built in motion analysis, or an OpenSim one. Okay. Then quantify muscle data, onsets and activation patterns, subdivide data by limb joints, and then subdivide each GC by, what is GC? I also don't know. By functional phases, yes. Then you move on for data compare the from your control and pathological cohort by using correct statistical means, and then finally you have a clinical recommendation. The clinical recommendation, it says that in cerebral palsy level 1 disorders, when we compare them with the controls which are age matched and gender matched, then we find that there is a loss of this motor function and there is a power expenditure on this joint for walking pattern or for activity. This is what we can conclude using CGA, using clinical gait analysis. Okay? Questions? Questions? Data analysis, anything. You decide where to be used. As long as you get me the data I want, or analyzing the data I want to analyze in a correct way. No, your markers are not placed on. I want to cover cerebral palsy, but I don't think there is enough time for us to cover it. So I'm going to skip it. And I'm going to next one. Topic is clinical versus rehabilitational gait analysis. So when you do clinical gait analysis, purpose, and when you do rehabilitation analysis, there is another purpose, and we will see what are these differences. First, pathological gait is clinical gait analysis. It's a comparison with and rehabilitational gait own data as a baseline. Analysis of disability, and here you monitor the post-intervention progress. In clinical gait, you find out impairments in the gait, and here you find out improvements in the gait. One, your clinical is affected by subject data variability and measurement errors. Here, finally to this, it is affected by variability. Gait analysis normally taken at one time stamp. Rehabilitational gait analysis is a longitudinal study on same cohort, same group of patients visiting the lab every 3 months. Okay. Clinical gait analysis is used to make medical diagnosis. This is very important. We are not capable of making medical diagnosis, the clinical gait analysis. It just helps to understand things better. It is not yet approved for use as a medical diagnosis tool. Because, can anybody tell me why? Anyone? Sorry? Yeah, I'm asking why. Will you say or quantifications you did are 100% accurate? Will you say why you can? Because there are possibilities would be very crucial for data analysis, and data exist in data analysis. first and foremost, and it may not go away anytime soon, the first and foremost error that gets introduced is because of the way you measure the gait. How do you measure the gait? You place what on the bodies? Markers. Now you assume that when the markers move, the bones inside are moving at the same way, in the same way. Is that the case? No. I put marker on my humerus here and I move my humerus like this. The marker is moving differently than the bone inside, and it's very, very obvious. So there and then only there is an error. Yes or no? You put a marker on the thigh and you walk. When you walk, your thigh moves about 5 centimeters here and there, which is not in connection with your bone. So now we have a problem. What is the problem? There is an error in your measurement system itself. But there are ways to deal with that error, which we will see now. But because of this main problem, clinical gait analysis is not used for diagnosis. It only helps. That all the time. Okay. So obviously, there is a limited repeatability in clinical gait analysis. There is a variability between sites and systems. Your lab doesn't match with mine. We have different ways and techniques to measure things. So the repeatability is lost. And then there is a variability within subject trials, which also introduces some limitations. Sources of error: experimental, model calibration, and soft tissue artifact. Soft tissue artifact is the one I talked about. Skin, the bone underneath. There are experimental errors like, what could be then experimental error? Placement of the markers, data acquisition errors, delay sampling, or using wrong samples, or using wrong population. Instead of just one level of pathology, you include all of them. That's an experimental error. Yes. A consistent, comprehensive, and clear method for describing this kinematics and kinetics is needed, which is not in place. You use OpenSim, somebody uses some other software called, let's say, Anybody. Somebody uses some open source, another open source software called BTK, Biomechanics Toolkit. So everybody uses some different softwares to analyze. It is not standardized, but you still want to prove that yours is better. So these problems exist, not only in this research. Every research has this type of problems, but we need to identify the problems in our research. That's different. The way OpenSim is designed and built is not the same the way the other softwares are designed and built. You will not find many different capabilities in other softwares, or you will not find some capabilities in OpenSim that are there in other softwares. For example, in OpenSim, calculation of moment arms is very difficult, whereas in couple of other softwares it's very easy. You see? Then we want to understand, why do we walk the way we do, or pathological. In that category, there is is a lack of patient specific models of walking. We don't have a model of walking for a Parkinsonian gait, ataxic gait, choreoform gait, or other gait patterns. We don't have these models to always go back and compare our results or our data. That's one of the big limitations. And then there is a lack of simulation based intervention techniques. That means we do not have the intervention techniques that are based on model simulations, because the simulation techniques themselves have errors. We are trying to resolve these errors over these years, but we are still not there to say confidently that this is what is happening to this guy. You take this guy, go to this rehabilitation therapy. You cannot say that with 100% confidence. This might be the cause of this pathology. Now I refer to clinical preference. Okay. Well, even in radiology, the radiologist see the tumor there, he will still say that go back to the clinician or go back to the doctor, even if he can see that. So here it's you can even not see many things here. So how do you manage error? Natural variability exists in the gait of persons. When you have a robotic arm and you want to move that in particular fashion, it will always move that way. But if you ask me to walk in the morning, afternoon and evening, I will walk differently. That means within me I have variability. And if you take walking data in the morning and you find that there is a difference, that's not the error of the experiment, that's my internal variability. And you need to understand there is an internal variability in everybody's walking. The ability of clinicians to discern findings that are meaningful from those that are insignificant or artifactual. So it goes back to a clinician's responsibility to understand the findings in a meaningful way. If clinicians cannot understand what is coming out of the gait lab, it's useless, because they are the one who are going to decide what type of rehab strategies you are going to implement, what type of follow-up process you are going to have, what type of disability or pathology is suffering from, to what level, to what extent, and what should be the first cause to be targeted. All these things clinicians are deciding. So if they don't understand a meaningful outcome from this CGA, how they can treat the patient, or how the CGA will help them? No, it will not. They will just take it in the dustbin tomorrow. So what you need to do is you need to educate clinicians. Most of us are engineers and only one clinician here, which is very brave, I think. Not many clinicians have this research oriented mind. So what we need to do as engineers, we need to go and talk to clinicians and ask them, what do you don't understand when you treat a patient? Obviously they will just slap you when you ask this question, but you have to ask it in a different way. Like, tell me what you want to know better in certain pathology, and they will tell you, this is I don't understand when I patient. So then you will devise the ways to look at that particular parameter using gait analysis. See? Then comparison of patient data to control data forms the basis for clinical decisions. frequently asked question is to deviate control, it is significant. And this is an unanswered question in almost every pathology. When you have a pathology, you have a rehabilitation. When you have a rehabilitation, you are improving. But when you say that you are improved enough to be normal, that is still a question. Yes.
How many degrees does whatever segment has to deviate from control? We can say that there are some things which improve naturally by themselves. May not be the effect of intervention.
May not be.
You can say that there is a significant effect because of intervention. So I think question becomes important here.
In both categories, it does.
So there is something called clinical important difference which you can have everywhere. So if the person has exceeded minimal clinical cutoff point, you can say that the person is improving or because of your effect.
But that's still a question, right?
I didn't foresee this, that's all I know.
You did foresee. So now there are specific sources of experimental errors that are widely known and well characterized. For example, effect of thigh coordinate system alignment on the hip and knee kinematics. Experimental error with observatory site, commercial system, and for doing a clinical gait analysis. As long as you know what type of error you're dealing with, you're okay. If you just don't know that there is an error and you're producing results that you are analyzing without knowing the error embedded in those results, it's a danger. See, two error estimates are closely related to gait analysis. Estimate of the standard error of the control and patient's data. The standard deviation of control data used as the sole measure of what is EE? Wrong approach for three reasons. Having a standard deviation and reporting it as an error is a wrong approach. First, standard deviation of the control data embeds EE with natural variations in controls. Somebody said something? Yes. EE is experimental error. Patient gait is compared to able-bodied average and not random. Thus, uncertainty estimate is a standard error of mean and not the standard deviation. And if all uncertainty is attributed to control data, then underlying assumption is there is no experimental error in the patient data. So the take-home message here is you do not report standard deviation as a means of error. You report standard error of the mean and not the data. Then most gait labs have an standard error of their control data. And this is the first thing everybody should do. When you have a gait lab, you should have an estimate of your error with regards to the setup that you have, with regards to the units and instrumentation that you have, with regards to the protocol that you have in place. You should have an ability to estimate the standard. And once you have that, then you can analyze your results better. And standard error for an individual patient is typically never reported. It's always reported in group of patients or group of controls. So again, the error management, we can go over it quickly, that we could have an intra-subject and inter-subject error. We could have an intra-observer and inter-observer errors. which could be intrinsic and extrinsic, that would lead to some variability apart from the patient's variability. Then estimating experimental errors and incorporating error estimates into data interpretation is important step when you process the data. What is the future of the gait analysis now? MRI or CT based gait models, from marker based to markerless systems, that would improve or eliminate one of the errors that exist in the measurement system. Portable equipments like 2D video analysis or even 3D gait analysis, which are easy to carry and easy to set up at any environment, in the fields, on top floors, in swimming pools, in very different environments, like if there is raining or if there is something is like a fire going on and you want to jump over the fire or something, you can place these instruments there now. Evidence-based therapies using gait analysis and predictive simulation models. This is an upcoming or the future of the gait analysis. And the use of gait analysis as a treatment tool and not only a diagnostic tool.
What is the disadvantage of accelerometer over analysis?
First and foremost is the joint positions are not known. So what you cannot do correctly is to assign the accelerometer readings to a model. And second is the repeatability in placing the accelerometers at the same location every time for every patient for same bony landmark is very low. See, for example, you can place a marker on the medial and lateral condyle with the palpations and very easily. If you place an accelerometer, most likely you have to place it in the middle of the segment. If you don't, and then you assume in your model that it's placed in the middle of the segment, that becomes an error propagation or source of error. And the third point is the that are coming from the accelerometer, they are not always true. They consist of multiple sources of acceleration. First of all, when your tibia is moving relative to femur, the acceleration is in tibia is composed of femur as well. Simple as that. So you need to be able to extract the pure acceleration of tibia to understand what is going on or to convert that into a model. If you cannot do that, or it introduces a source of error there. See, that's why. You tell me. Let's say both have their advantages and disadvantages. You can put multiple accelerometers covering the entire lower limb and you can still get a meaningful results out of it. Yeah. Or you can make a very stringent and controlled protocol for the markers and you can still get a good data out of it. Like for example, I will give you an example that I am using in my research is that for the equinus patients, we are using something called Oxford foot model or Oxford marker set model, which is very stringent and a controlled marker set that would allow you to understand every single motion of the foot as the person walks, as against the normal data that you only markers on your ankle joint and everything. Here you have like about 16 markers. So you increase the resolution of what you are looking at in the marker based systems, you would have a better results, but that's not always feasible. See, you also have to see the feasibility. Okay. So there are some references. Say that again. In a 2D view. 2D view. How do you marker in a 2D video? By image processing. He can tell you. Say that. Frame by frames we can do it. You can do image processing to extract the background or eliminate the background and only identify the markers, and then you yes. Questions? No questions, we take a tea break and then you come back and you start your projects. Okay? Thank you.